Welcome today to a webinar from CEG. My name is Chris Cavallo. I'm one of the clinical directors at CEG, and I'm here to talk about the network contract DES. I'm going to cover a couple of things on this. So a brief introduction to CEG, who we are as a refresher. Hopefully you do know and are aware of that already. And also hopefully you're aware of the network contract DES and what that service requirement look like. But really, the essence of this is to explain what it is in our toolkit that's going to help with you achieving that, giving an overview of the support, including the searches, the templates, the dashboards, and the tools. There's quite a lot to get through on that, so we'll try and go through at some speed, but allow some good understanding, but give us some time for some Q&A as well. So hopefully you're familiar with CEG, the Clinical Effectiveness Group. We've been around for about 25 years. We're a group of GPs, analysts, data scientists, and facilitators based at Queen Mary, and we have access to all of the primary care data across now. And what we do with that is we build the dashboards, the searches, and the tools to help primary care, to help the GP teams, help the commissioners develop the services, and help inform public health. And with that, it's not just about the data, it's about the facilitation and support to give to practice to help you use those tools and maximize population health improvements. Being based at Queen Mary, we also are involved in research, and we do publish papers regularly on the data that we have from primary care and creating those insights. And the funding comes from the NHS, local authorities, and our research grants. We cover the whole of North East London, so we have access to the data from all 266 practices, EMIS and System 1, which equates to about 2.4 million patients. And that allows us to support primary care working to improve the efficiency and the effectiveness with our partners in primary care. But really, we're based around the clinical effectiveness approach, and you'll see this when you look at the toolkits, where we take data at the center and we use that data to inform the work that we do for quality improvement. We create those searches that help with call recall, disease registers, and help to understand our opportunities. We have templates which ensure we've got high quality, smart data entry, and then we have dashboards that help to monitor and motivate us to make improvements. That's also supported by our software tools, and you will be familiar with our Apple tools and hopefully attended our recent AF tool webinar, our next generation tool. For all of those to work, though, we need to provide some support, and so that's where our facilitation comes in. That's facilitation of how to use the tools and how to translate that clinical knowledge, guidance, research into frontline clinical care. But that one says the same thing. So with this, I want to start off with a good news story. And some of you may have seen this already in the news items and heard from others, but we've had the data from QoF from 24-25, and we've undertaken some analysis of that at CEG. And as I say, it's a very good news story. In total, there are 48 clinical metrics in QoF, and Nel was the top performing ICB in England. We were top in 12 of the 48 metrics, and we're in the top 3 in 23. So that's the best in the country, and definitely the best in London as well. What that does hide, though, is some variation. And this is, I think, where we need to work on next. We've got some very high achieving practices and some very high achieving areas, and that masks some variation. And you're always going to have some variation, but what we need to do is try and tackle that variation, both geographically, so across across Nel in the different boroughs and the different practices and the different PCNs, but also demographically in our different population groups. So some work to do, and some of what we do in the network contract DES will help to tackle that. The DES is there to provide funding to support PCNs to enhance the resilience and improve care delivery at scale, primarily by improving health outcomes through population health management, reducing health inequalities, and collaboration. That gives us better integrated care for our patients. There are 4 key functions in the PCN, but what we are going to focus on today is how we tackle those bottom 2. I've slightly put them out of order because they group together better. But really what we're focusing on is improving health outcomes through effective population health management and reducing health inequalities and targeting the resource and efforts to deliver proactive care. That's then what we look like in terms of the offer that we've got. So in very simplistic terms, what we're saying here is that you have a DES, you have a requirement to achieve in that. here's the support that we are going to provide to help you achieve that. That's in the form of searches, so the support searches and the indicators searches that help with the DES. There's the data in the form of the dashboards, and there's the templates for the data quality. But supporting with that is to go further with our CG tools, so the AF tool, the renal tool, the cancer diagnosis audit tool, and any of that are coming along the way. And also with the support we provide, either direct support from our facilitators or the written guidance that we provide on our website. And you'll see this tool on our website when we launch this program formally in the next few weeks. But the searches are going to be ready pretty much straight away. I'll go through what we offer and I'll explain a bit more in detail about how they all link together. But before that, you hopefully will also have seen from the Nel Primary Care team a payment template. So this is the requirement of the DES for you to receive the money that's included in there. And I'll leave the detail to the primary care team to explain, but I've included it in this slide deck so you've got the information there. There's a template which you need to fill out and submit to the primary care team. That will then release the funds that you've got. And so there's 0.45 pence per, 0.45 pounds per adjusted PCN population for the risk stratification domain. And they will ask you in that template about how you have been undertaking risk stratification in that. Those completed domain templates should be sent to that email address there. But again, if you have any questions, please do contact the primary care team for more details on that. So with those 2 bullet points that I mentioned earlier, you can break them down a bit further. So in terms of improving the health outcomes, there are 4 sections. There's the CVD prevention and diagnosis, which hopefully is familiar to people from the previous iterations. Again, similarly, the early cancer diagnosis, and then we'll talk about how they ask to tackle population health management and health inequalities alongside some of the other things that are available across NEL as well. And then thinking about the other bullet point, which is around targeting resource and efforts, and particularly around proactive care. But with that, and thinking about population health, how we take a larger population health view and tackling that for those who are just below or lower down on that pyramid. There's other sections on structured medication reviews, medicines optimizations, social prescribing, and enhanced health and care homes. In terms of the care homes work, I think you will hopefully all be familiar with our local DESs, so that really ties into delivering on this, and that's probably about as much as you'll need to focus on for it. But that's the main focus for the care homes work for the DES. Running through the DES and running through the details is a real ask around data, the analytics and the monitoring. And one of the functions for the DES is to allow the PCNs to come together to understand the data, understand the population health needs, but then allow you to target resources effectively, and then ultimately lead to improving health outcomes. We're very lucky, I think, in North East London to be able to have the data that we have, and not just talking about the data that we've got through NEL, but wider than that. We've got really rich data, and I think we've got also very experienced in being able to use that to be able to improve our health. The approach that we have taken and we've been working on for a long time is how we look at that and compare it across different practices. So that benchmarking, that reviewing of variation is something that we should all be very familiar with. It's how we do that going forward and what we look at, because there is so much to be able to do the analysis on. So it's very important that the system is there to support the PCNs in that analysis to be able to do the improvement, but then also look into how that ties to the financial payments and their workforce. Coming on to those items of those bullet points, I'm going to take them one by one and give you a bit of an overview as to what the ask is and what there is in support. So in CVD prevention, breaking that down further, we've got an ask to look at the detection and management of CVD risk factors, the detection of hypertension, detection of AF, the identification and management of raised lipids, and earlier identification of heart failure. What we've created, and then you'll see it in the support searches, is a folder for the network contract DES, which has all of the searches pulled together. There are lots of them in there. There are some direct ones and there's some support searches as well. what I would ask is actually you start to have a look and play around with that, start to run them, and then when the dashboard is run for the 1st of October date, you'll be able to see your baseline data and know where you want to progress and what you want to target on, as either as your individual practices or as your PCN. And that's down to you to determine in agreement with your peers. The key for this is that there are the searches there to tackle this. The other thing there, though, is that we provide our templates. And in many of our templates, we often need to develop some new ones for each of the contracts. And that's really then to make sure that we are collecting all of the relevant data through the right codes so that we can improve the health outcomes and reduce inequalities with good quality data. And we've got lots of templates. We've got some very complex ones. We've got some which are smart. For this, what we're primarily saying is that we want to make sure on our end that you are able to use templates that are easy to use, that they're not complex, but they have all the things that you need to do in them. So our templates will be able to do that, and they actually have more than that in there. So they have things also around specific pages for ethnicity and language and other determinants, which helps with your inequalities data, but also helps you to collect more than what you would necessarily need for this. But also, we also have additional templates outside the LTC one, which looks at the social prescribing, structured medication reviews, and health checks in the boroughs where that's provided. So CVD risk factors. So this is one of the key elements in the DES as one of those bullet points, but breaking it down into the CVD prevention section. With that, the first ask is to collect your data, review it, and share it. So that is one of the key aspects of what we have within our data, either in our existing dashboards, and for many of your local contracts, you'll have metrics which are looking at this, but we also have our local data, our practice trend data, to be able to analyze this and to see it in more detail. And that should then go towards the development of your pathways and improve your diagnostic capacity for the ABC testing. So that's testing around AF, blood pressure, or cholesterol. So the key thing here is to look at your data, to share it, discuss it, and then develop from there. With that, also they also ask that you support information exchange with community pharmacies. I think from what I can see, definitely in my practice, we're doing pretty well on that. We are able to get it, but often it's not always the coming down through the link. It sometimes is coming in paper form. So it's working with the community pharmacists to make sure that they've got robust ways to be able to send us their details as well. Detection of hypertension. This is an indicator which should be familiar to you from IIF, from the very inception. The ask of the DES is to follow up high readings in people who don't have hypertension to offer a new blood pressure test, or plus or minus a diagnostic test. To either repeat their blood pressure, if it's still high, then do a diagnostic test. The other ask of the DES is to improve the coverage of blood pressure checks. So that's the opportunistic ones, or thinking about working in your areas around outreach or working with community pharmacies. The suggestion then is to run the search that we have to find those who are not on the hypertension register but have had a high reading, then to bring them in to do a repeat reading, or to get them to have a repeat reading done at the community pharmacy, and to have then a 24-hour blood pressure. What we also find is that patients do have their own machines, increasingly so, whether it's people who have hypertension, but often people who don't, or they have family members who have a machine. So get them to send in their own readings and do the 4 or the 7-day home blood pressure readings to be able to look and see whether they have truly got hypertension. If you're looking to find whether or not you have a pharmacy nearby who does offer a blood pressure check, or you want to send that link to the patient so they can find one, the NHS website has got a great service to be able to find a pharmacy who are offering blood pressure checks. In terms of that second point of the DES ask, improving coverage of blood pressure checks, there's two other additional things I think to think of. Great, yes, let's do some work with our local communities, thinking about how we can do blood pressure checks out there with them, making sure that they are supported to know what to do with those readings, but also thinking about where else we have captive audiences. And we know that from the COVID clinics that there was a really good trials of doing checks as people waited for their vaccines. So right now it's 1st of October. We're thinking about our flu clinics. That's another key opportunity to do blood pressure checks. And then many of you will already have machines in reception. And I think a lot of us have thought about getting those pods, those big machines that sit in reception and can send the results through. I think we've all had varying experiences with them, but as simple as having a machine and a piece of paper for people to write them down and hand them into reception is as good as that. So making looking at your reception space and the opportunities there to be able to do those, to be able to offer a blood pressure machine check in reception is another suggestion. In AF, it's about improving the detection of AF. In NEL, this is already part of some local contracts. So there are some indicators already around offering pulse checks opportunistically, which is what the DES asked for. But it also says, and as a reminder, the key time to do that is the same time as a blood pressure check. So making sure that you've got a regular rhythm to make sure the machine's going to be able to accurately check it. But that's a key time. With that in mind, as well as doing the blood pressure checks in flu clinics, the pulse checks are another opportunity there as well. We will be getting reports from pharmacies, and while it's not always necessarily a national ask to be able to put a pulse check in, they will we have been working with the local pharmacy committee to be able to put that in. So it should have whether they have an irregular pulse. So it's important to code that. But this is about detecting abnormal rhythms. So if ECGs are undertaken, trying to make sure that you're looking for the pulse rhythm in there to code as well. And if you aren't, and if the opportunistic pulse check isn't part of your local contract, what I suggest is you prioritize those people who are going to be most at risk if they are found to have AF. And the easy way to think about that is thinking about CHA2DS2-VASc. So looking at your population who are either over 65, who have heart failure, have hypertension, who've had a previous stroke, who have cardiovascular disease or who have diabetes, because those are the people who will then score highly on CHA2DS2-VASc and will need to be anticoagulated. So if you're going to prioritize, that's where I would suggest that you do it as well. I don't look at many ECGs, but looking at that one, I don't think that one has AF. But if anyone does spot what the arrhythmia is on there, put it in the chat. Let's keep going. Okay, lipids. Again, this should be familiar. There's two parts to this. The first one is about just managing raised lipids. So offering statin for either those people who have a high Q risk, just a reminder that's Q risk above 10%, and either using QRisk2 or the online QRisk3 calculator. And then in secondary prevention, we used to really hammer home the point about a high intensity statin, but you'll see from the guidance, you'll see from QOF, and now also from this, the ask is in secondary prevention. So those who've got a history of heart disease or stroke to achieve an LDL target of less than or equal to 2. They also include a non-HDL indicator in there, but our breakdown gives you an LDL. So focus on that LDL of less than or equal to 2. But before I come on to health checks, on that, the searches we have will find the patients who fit into those categories, but that is reliant on them having the data coded correctly, and that includes calculating the Q risk. It used to be the case that we'd always recommend to batch code a Q risk calculation, but with that functionality now removed, it's important to still do that to recalculate the Q risk as well. So run the searches, see who is eligible and not achieving, look at those who aren't coming up on there, thinking about recalculate that Q risk score. But in terms of getting them onto the right treatment, there is very, very good guidance from the Accelerated Access Collaborative, the AAC. And in that, I'm thinking particularly around secondary prevention, is guidance on the up titration to be able to achieve the LDL. You will have patients who are intolerant, and it's difficult for us to try and compete against all of the media campaigns, the newspapers, social media, the friends and family who provide negative views and opinions of statins. But if people are complaining about intolerance, there is a very good guidance on there to be able to manage that identification of statin intolerance. So again, these are links in this, so I'll click on those and have a look. One other link, not into the AAC guidance, although it is inclisiran is mentioned, but in terms of inclisiran, that is a key medication once you're on statins and maximize the statins to be able to get the LDL target down. So LDL value down to the target. We have guidance in now on how to implement the inclisiran injections, and that is on that link as well. It's something that we haven't been high prescribers of, but with the rebate, which I think now is £15 per injection, there is definitely something there to be thinking about in terms of increasing the use of it from a financial perspective. Really, there's good evidence about getting it down, the LDLs down. So on the other part of the raised lipids, there's the asked to improve the uptake and delivery of the NHS health checks. So we've mentioned around the templates and where there is a local spec or around NHS health checks. But the important thing here is to review that data. So either using the local data or using the data on PHE fingertips. And then also within your practices, within your PCNs, to run the searches and to look and case find, and look for people who are eligible, who haven't done it, and then think about how you can target that either through direct contact with patients or through some community engagement. The other part of cholesterol is around familial hypercholesterolemia. We did a huge amount of work on this when the IF was initially produced. The indicator there asks you to search your records and find patients younger than 30 who've got a high reading of 7.5, or over 30 who've got a high cholesterol of over 9, and then apply either the Simon Broom or the Dutch Lipids Clinic criteria. Great calculators online, and it should be there on the template as well. But if you have probable or possible FH, initially IIF indicator said that you should just refer anyone who had a high reading, but there are things that we can do in primary care first to see who truly does have suspected familial hypercholesterolemia, because there may be other reasons, and that's what this flowchart helps to guide you on, so that you can work out whether or not you do need to make that referral, or whether there's an easy explanation for it that you can find as well. So we've included that on there. There are local services, but there are long waits for them. But don't forget about advice and guidance as well. But there's a search to be able to find these patients to start the process. We had different tests and trials, and we had some good experiences with pharmacists taking the lead on this, and in some areas also having a dietitian do this as well. So maximize the use of your additional roles to be able to find, to run all of these searches and to find these patients. Right, the final one in the CVD prevention is around early identification of heart failure. This is on the right is the national pathway, but we do have local ones as well. But this is the national one, and they don't significantly differ from this. But essentially, this is around using NT-proBNP and knowing when to refer, when to request an echo, when to refer into secondary care. So once you have a patient with symptoms or signs indicative of heart failure, completing that blood test form, making sure NT-proBNP is on there, and then if you have a high reading of above 400, knowing that you can refer for an echo, but that in terms of the value is how urgent it is. We do have great services across now, and I think we should be able to access them fairly well. We have variation in terms of the provision of support for heart failure, but one of the things that we can do is make sure that we are diagnosing early, because we can see from the data that there is a long journey for patients to get that diagnosis, and then when they do, they are very unwell, and the prognosis is not great. So it's very important to identify heart failure early, but also to code and classify that correctly. And we've got a whole suite of searches that help you with this more than what's in the TES. Those will help you to find those patients, to improve heart failure diagnosis, get accurate coding, and also support of management. So making sure they're on the right medication for their symptoms, and that's all included in that suite of searches. So moving away from CVD, we're going to talk about cancer, and there's two real things in this that they're asking in the DES. The first one is around reviewing the cancer referrals, and the second is about improving screening uptake. The first one about improving referrals, the aim there is to increase the early diagnosis rates and improve the referral practice and also the processes as well. And that relies on the PCNs working with the cancer analysis to improve that referral process for either the colorectal, lung, or one other type determined locally. So make sure that you're in contact with the Cancer Alliance around that. But one of the suggested actions is around auditing your referrals. And that's one of the tools I mentioned at the beginning. The Cancer Diagnosis Audit Tool allows you to do exactly that. So that's designed to support clinicians to look at the cancer diagnosis and identify avoidable delays, looking through the referrals, looking at the process and the diagnosis. So the tool, as you saw just on that previous slide, it displays the demographics and other information, including comorbidities, the age of diagnosis, and the tumor group for each person that you referred. So then you can go back through and review the delays according to those particular characteristics, and then take steps within your practice to prove the equity of care. So that tool helps you to review your quarterly activity, helps you to work smarter through autofill audit fields, and helps you then to address the inequalities, which we can see by looking at the patient demographics and the comorbidities to be able to then improve the referral process and journeys for patients. The other aspect of the cancer ask is around the screening uptake. So that ask is around promoting increased and appropriate uptake of screening. The suggestions include examining variation, auditing non-responders, and every contact count, and making available use of resources. With those resources, one of the things that we have here, there's two dashboards. In fact, we've got one of them on the screen, which is the cancer screening dashboard. So that provides data on cervical, breast, and colorectal cancer screening to allow you to see where the uptake is good, where it needs improvement, and then for you to be able to use the tools in your practice systems to do that auditing process, to do that review as well. The other dashboard focuses specifically on ethnicity. And so if you haven't had a look at that, go onto the CG dashboards page, have a play around, have a look to see what that data looks like for you in your practice or your PCN, and then discuss with colleagues and think about what it is that you could do to improve, or what you can do to share with your peers about why it is that you've managed to improve your achievement as well. Moving on, there was an ask around population health management and health inequalities, and this is a hot topic as we move with PCNs and neighbourhoods. And there's been a lot of work done around this and promotion of some great tools that we've got in now. So the DES asks that the PCN must seek to improve health outcomes for its population using a data-driven approach and population health management techniques in line with guidance and core 20+5. In terms of health inequalities, it asks that the PCN should actively seek to reduce health inequalities across its practices in line with guidance and the core 20+5 approach. So with this, it is really primarily around understanding population health management and how to use that on the front line, how to use PHM approaches to improve service delivery and help improve patient access and outcomes. There are a range of different techniques which we can use to look at that, to explore the data, to assess the needs of the population groups. And one of the big asks there is around the core 20+5, and I've included a link in there just so everyone gets a refresher. So the infographic does really a good job at helping to understand what that means. But 2 of the 5 clinical areas in the core 20+5 approach is around what we just discussed, around the cardiovascular disease and early cancer diagnosis. This slide is taken from the NHS features page from Population Health Management. I'm not going to go through it in detail, but for this, you'll see that there is the population segmentation, which starts at the top there, although this is a cyclical process, but starting with the population segmentation, that then allows you to understand the wants and needs of your population alongside the priorities, and then how people interact with the local healthcare services. In the practice, that really what then happens is need to be able to drill down into that data to identify the population and to risk stratify them further to be able to understand what you will then do to avoid deterioration and to avoid avoidable health service demand. There's more to it in that in this, and I think this speaks to what we I think are good at in now, but it is that the collaborative approach and thinking about how we work across our partners, whether that's across the health system or across our local communities, to then improve the health that healthcare that we're providing through collaboration. Won't go through this slide, but that's just the other one that was included in the NHS features page. With population health, there's a need for us then to think about how we are delivering good care, good multidisciplinary care for our patients with complex health needs. And these are the people who will be at greatest risk of deterioration and hospital admission. So these are the ones who are going to be costing the system the most. These are the ones who are going to be going up to A&E, getting admissions, having long stays. These are also the people who we are going to need to think about how we help them get the care they need and help them get the access to our primary care service as well appropriately, so that we can effectively manage them. But with that comes a demand on our service and our time. For me, this is really about thinking about how we work effectively and efficiently. And for this, we need to be able to risk stratify. We need to be able to identify the target cohort who are coded accurately to be able to identify them, develop the right care and support plans, and then coordinate that really multidisciplinary team that we have in primary care and community to make sure that we've got good continuity, good care, and good access as well. And I think that's where the DES really hopes that the INTs will play a strong role in. But to do that, we need to be able to it comes back to the use of data. The use of analyzing the data, understanding it, using tools like EFI or understanding EFI 2, I think it's coming out soon, which gives a greater detail of analysis of frailty, but also using our clinical judgment and clinical validation to prioritize care based on what we know of our population. The challenge that we have is that if we look at the population health pyramids, these are the people who are at the top of the pyramid. And for population health, the argument is purely focusing on the people at the top of the pyramid isn't an effective way to reduce mortality. Now, it matters to those, and I think it's still really important that we do what we can and do target and provide the care that we need for that population. From a health system aspect, it's a small population that takes a big amount of effort and input. And ideally, what we would be doing is focusing lower down on the pyramid, so that where we can have a greater impact by doing the things that we need to do. That's the effective and safe interventions. That's around optimal medication. And if we can go further and lower than that, which I think this does direct us to, it's very much around population health and prevention from an early stage that has a greater impact. So on that risk stratification, yes, there's a risk analysis that we need to do for those who are have the most complex health needs. But even before that, we need to be able to identify those who have a risk and be able to group them based on the risk of future adverse health events. Again, that relies on the clinical data. That also relies on us being able to understand the evidence and the guidance and how that applies to our population with the variation that we have in demographics. That then allows us to categorize them as high, medium, or low risk, and that allows us to prioritize and tailor care. There are ways in which we can do this, and we've been through, I think it's fair to say, a journey in different approaches, and there are merits to all of them. And I think it's really about having an approach that works for you to do that prioritization as well. There are complex ways to do this, and I think there are some who have got real benefit from being able to use some of the more complex ways to risk stratify. But I think with the demands in primary care, it's not necessarily feasible to do a really detailed analysis and risk stratification in all circumstances. And there is capacity and capability that we need to be aware of. So the support that we provide gives people the tools to do both, to go in and drill down into the detail, to really target that risk stratification, or to use something that gets them on that journey, to get them a start. So when we've looked at this, we thought there are our existing tools like Apple Renal or the AF tool, which you would have heard about last week, and there are our searches, and the searches which we have created, which simplistically look at prioritization by deprivation and by ethnicity. That's a very crude way of looking at it, but it allows us to look at our core 20 most deprived populations, as well as looking at those who we know from the data and evidence are more likely to not achieve key clinical metrics or have adverse outcomes than other population groups. This is a start and allows us to make a move in that direction for those that are wanting to dip their toe in and start that process. But for those who are more experienced, there are other tools we've got, and there is definitely more support that we are providing for risk stratification, which we'll go into in a bit more detail. Coming back to the DES, and just briefly, there is an ask around structured medication reviews. I don't think that's new. The ask there is to undertake medication reviews to improve medicines optimization, particularly on high-risk cohorts, to reduce polypharmacy harm, overprescribing, and risk of dependence, but also looking at those who are the high risk, and that's what the searches help with on both of these, is to look at those who are in care homes, with those with learning disabilities, with complex problematic polypharmacy, medication associated with errors, frailty, and some dependence-forming drugs. Apologies for the misspelling there, but also focusing on health equity. One of the other items was around social prescribing, and I think for me, as a clinician, I found really benefit from referring patients to our social prescriber. But what we need to make sure is that we are appropriately providing this for our population. And so making sure that we can identify the cohorts who will benefit from social prescribing, who have needs which are around the practical, the social, and emotional needs that affect their health and well-being, and knowing what the social prescriber is able to offer to individuals and populations. So our searches provide a list of patients who may benefit from social prescribing, but what we're not saying is that everyone on that list needs to be referred into the social prescriber, and I don't think they would be able to cope with that given the population that we have. But what it is allows us to look at that information and then be able to target approaches to ensure that the service is there for everyone who needs them, but everyone who needs them the most. All of this is available on our dashboard. So we are just running the data for the 1st of November, so we'll be able to process that through and share on the e-bulletin when that is ready. Searches are ready to go, but we'll be launching the dashboard via the e-bulletin when it's got the most up-to-date data. So if you haven't signed up to the e-bulletin, contact your local facilitator. They'll get you onto their mailing list. Make sure you get everyone on there because it's got more information and more important things around contracts, etc. But it gives a wealth of information, and it gives you a way to make sure that you know who your facilitator is and when you can drop into them or how you can contact them otherwise. So the dashboard provides GP practices with the activity around some of the key indicators. Not all of the work in the DES is able to be turned into an indicator, but where they are, we have included them in this. And you'll be able to see the breakdown through the levels of ICB level, borough level, PCN, or practice, and allows you to then to look at the top achievers and those who who are potentially looking to improve, and also to look at the trend of that across time. The other one, the gauge diagram, also gives you an idea of what the numbers look like, so what you need to be doing to improve. There's a link to the dashboard. I think that is the most up-to-date link. I will see if I can come back to it, but I'm just conscious of time. So I'm going to plow on. So we've talked about the searches. We've talked about templates. We've talked about dashboards, and I've teased a bit about the Apple tools. So we have historically had a range of Excel-based Apple tools, which assist practices in doing that recall, doing the monitoring, doing the optimization. And the ones that we currently have are on childhood IMS, on renal, and we also have one on NDPP. Last week, though, hopefully you attended Mike's webinar on the AF tool. This is a new way of doing things. This is a web-based tool which imports your local data, or you import your local data into it, that allows you then to review and optimize your patients with AF. This then allows you to work more efficiently. It allows you to risk stratify. It allows you to easily identify those who are at risk of strokes or bleeds, look at them to see about medication, look to see who needs optimization. But ultimately, this is about reducing risk. It allows you to create a list, to create a cohort of patients for you to be able to examine, to export that for you to take action on. But it gives you the ability to prioritize in your way. But it also allows you to review your individual patients and look at their metrics singularly as well. So it looks at them as for a patient view. This is the future of our tools. They're evolving to take advantage of newer software as we move the times, and based on the feedback that we've had, make them more intuitive, easier to use, and allows us to expand the functionality that we were previously restricted on. It's all browser-based and no special software needed. It should be a familiar process, and the AF tool is the new one, which is now live and available for practices in now to use. If you head over to the website, you should be able to get more detail on that. That's what it looks like. I won't go into too much detail, just to say all of the data on there is dummy data, but it's got a much nicer interface and better functionality. I'll point to one of the key things for me on there is the quick filters, so be able to easily filter for the key things that need to be looked at for the AF population, but also with those drop downs allow you to do that filtering yourself. In development are two further tools. One's closer than the other, but there are two tools coming which will help with your patient management, but also with your CV, your network contract DES. The first one is the CVD prevention tool, which you've got a screenshot of here, or just a highlight of it. This will help around identifying patient at risk of CVD. This will improve detection and management. So we'll focus on linking things like blood pressure control, around cholesterol, thinking about how we're prioritizing different population groups. And like the others, it's got fantastic quick filters, but also allows you to drill down into a bit more detail as well. For those of you sitting back, you will remember that we had an LTC tool. We're radically redesigning that because there is some good idea and good functionality behind it. But that tool, when it is launched, will give you an overview of your practice population who have long-term conditions, whether that's one long-term condition or multiple, which then allows you to risk stratify and prioritize. But it also gives you a snapshot of the key clinical metrics for a patient, so you can help streamline your recall so they have the care they need to done in a clear and efficient way. It's really about thinking about how you prioritize and work efficiently in your practice. Okay, coming to the end. What's new for 25-26 are these beacon projects. So I'm very conscious that what we have are a whole loads of tools, and we create these things which take clinical knowledge, guidance, research, as well as knowledge of how things work in practices, to develop these tools and these searches that take our local contracts and help you to work in your practices to achieve them. But I think there's a gap, and there's a gap between the development of the tools and the further support that's needed to really embed them within primary care. So as a pilot, what we are launching is a new program that allows you to work with your peers, with practices either within your PCN or across the network, depending on how many people we get involved in the scale of it. But what this is really focusing is about developing and implementing improved care pathways that take that evidence and take that data and does that healthcare transformation. So it's building on the evidence-based care to implement improved care pathways, but ones that work for you in your practice and in your population. But it takes that population health data to help guide what you need to do to identify your improvement opportunities and guide the strategic pathway design, but doing it in a way that optimizes your workflow and optimizes the use of your work force. So that is around how you do your patient recall, how you do your risk stratification, and how you do the medication optimization. That last box is really to emphasize this is about us providing that support to be the facilitation between the tools and you as a practice, building on what we have had success of over the last 25 years, but to really focus down on specific projects. The benefits of that will hopefully be enhanced patient outcomes, improved outcomes, also patient satisfaction, and also improved efficiency of access. That is around the efficiency through the streamlined processes around data-driven decision making. But it also allows us to look at our workforce, build the capability, as well as streamlining things to improve the capacity. But with this, it allows us to really see the improvement along the process, which will build the team morale and allow us to develop our staff. Professional development, a collaborative learning is really key to be able to drive the improvement going forward. And I think we all, as people working in primary care, in general practice, have that population health as core to us. And so working with our population, identifying their health needs, aiming to ultimately reduce inequalities, can only be driven by targeted, focused efforts, which is where this comes in out central. So this is very much a pilot. What we are looking for is practices or PCNs who are interested in joining, and we're going to start off primarily with looking at blood pressure control. And the reason for that is because while we can have a keen and enthusiastic team, what I think we also need to think about is how we make that a benefit to a practice or PCN. And given the financial incentives around blood pressure, as well as the drive that NHS England and Department of Health have around CVD prevention and blood pressures as a whole, that's the most sensible place to start. I am open to hearing what others will want to focus on, and we'll see about how we can accommodate that. But we're looking at a pilot. We want to know how, if this works and how it works. We know that the elements of this have been successful, and that's why we've achieved the QOF outcomes that we have. But this is about being able to look and understand that in a bit more detail and work with you as we have these new structures and these new opportunities. What we're really asking is you to express your interest. There's a link on there. We'll tabulate that, and then once we have identified suitable areas, we'll be in touch. But we'll make sure we have all of those who have expressed interests included and informed on that journey, so we can move towards you if you're not in that first tranche. But really, what we're looking at is people to nominate a lead, to commit to work on this. And that does take some time and resources, but we want to make that as limited as possible. That's not impacting the day job, but it's about how we share knowledge and how we engage with others and how we embrace a data-driven transformation. So with that, gaining the skills to be able to look at the data, to understand it, and then how do we use that for improvement. Ideally, we are looking for across PCN collaboration. There is learning to be taken from different PCNs at different boroughs, but what we really want to do is understand what's going to be the most efficient way of doing this. And given that contracts are various across the patch, this is why we primarily chose hypertension, but it may be that we need to think about that in a borough. So if you are interested in joining us on this to improve the way in which we identify, diagnose, and optimize blood pressures in our diverse population, click the link and sign up. and we'll be in touch soon.